The following podcast is part of a certified educational activity titled Breaking Through Biases, Collaborative Weight Management in Primary Care and Treating Obesity as a Chronic Disease. Access the entire activity and complete the post-test at peerview.com/TBR860. Downloadable slides and practice aids are also available.
Hello, everyone. Welcome to Breaking Through Biases, Building Skills for Collaborative Weight Management and Treating Obesity as a Chronic Disease. I'm Dr. Donna Ryan, and I'm Professor Emerita at the Pennington Biomedical Research Center in Baton Rouge, Louisiana. It's a research division of Louisiana State University. And joining me today is my colleague, Dr. Jamie Ord. He's a clinical researcher and professor of epidemiology and prevention and co-director of the Wake Forest Baptist Health Weight Management Center at the Wake Forest University School of Medicine in Winston-Salem, North Carolina. Jamie, welcome.
Thank you, Donna. It's such a pleasure to join you. I look forward to our discussion.
Great. So our goals for today are to have everyone walk away from this event able to apply the current guidelines and evidence to recognize and prioritize treatment for obesity as a chronic disease. We also want you to appreciate how important it is to initiate weight management discussions in order to establish realistic, long-term obesity treatment goals and to utilize shared decision-making in persons with obesity. Here's our first section, Acknowledging Gaps to Overcome Clinical Inertia in Obesity Management. So yes, we have a problem. There's an obesity epidemic in the United States. According to the last NANE survey, and this is shown on the right, that the latest prevalence of obesity, that is a BMI of 30 or higher, is 42.4% of the U.S. adult population. And severe obesity, that's a BMI of 40 or higher, that's 9.2% of the population. This does not affect all sexes and races equally. If we look on the left, we can see that in the first group of bars, we can see that obesity prevalence is highest among African Americans compared to white individuals, Asian individuals, and Hispanic individuals. However, if we look at the two sexes in the next two sets of bars, we see that African American men have actually a lower prevalence of obesity than do white men. The prevalence is highest among African American women, so about 56% of African American women have a BMI of 30 or higher. Now, many healthcare professionals don't treat overweight and obesity as the root cause of all the chronic diseases that are filling our appointment books. We're pretty good at managing type 2 diabetes. We're pretty good at managing cardiovascular diseases. We're pretty good at managing obstructive sleep apnea. But I think what we don't do is we don't be proactive about managing obesity, the driver of all of the chronic diseases that we treat on a daily basis. Look, obesity is itself a disease. It is a chronic disease. It is a progressive and relapsing disease. Our current guidelines and evidence support prioritized treatment of obesity. Why is it that we don't do it? Well, I think that part of the reason is that our healthcare provider cadre has some resistant bias to obesity. We oftentimes don't really see obesity as the disease that it is. We look at patients with obesity differently than we do patients with other diseases. And I think we fail to recognize the chronic nature of obesity. We expect patients to lose weight and keep it off when we know quite well that the chronic nature of obesity is that we should expect weight regain after weight loss. And I think we often see obesity as too difficult to treat. We don't really see it as treatable in our primary care practices. Look, we have very short office visits. How can we possibly give a comprehensive lifestyle training to our patients with obesity? And we're skeptical still about these new anti-obesity medications and we haven't taken up the use of our older anti-obesity medications as much as we should have. So how is it that obesity drives all of these comorbid complications? We all know obesity is a driver of diabetes, of cardiovascular disease, of 13 types of cancer, of many, many of the chronic diseases that are filling our offices. You know, there's a standards of care for obesity management, and 2 of the standards of care say that we should be assessing all of our patients who have high BMI. We should be assessing them for these comorbidities, and we should be educating our patients about the relationship between obesity and all of the complications that it drives. How much weight do we really need to lose to get some health benefits? Well, here I finally have some good news for you. We start to see improvements in a lot of the risk factors associated with obesity, and we even start to see improvements in how patients feel and function with moderate weight loss of 5 to 10%. Of course, more weight loss produces more health improvements. So, although we can get some health benefits with this moderate weight loss, 5 to 10%, if we have medications that can help us lose more weight, we can get more health benefits. We can get improvements in cardiometabolic risk factors. We can get improvements in how patients are feeling and functioning. We can get improvements in symptoms of sleep apnea if we can get greater than 10% weight loss. And we can start to clear the liver of fat. And as we know, NAFLD, fatty liver disease, is a big driver of fibrosis in the liver, MASH. So our goals are shifting in weight management. As we have more new tools to help us get more weight loss, I think we're really challenging our patients to let's set a goal for more weight loss to try to get more health benefit. But I think primary care physicians are just as excited as the general public about the opportunity to really help patients lose weight. But I think primary care physicians really face some challenges. They haven't really been taught about obesity as a chronic disease, and they haven't really been taught how to discuss obesity with their patients. So some of the materials that Jamie and I will be going through with you today may be new, and we hope that you will take them to heart. You know, I think it's so important that we begin to address obesity in primary care. And one of the best ways to learn is to learn from your peers. So we built into this program a train the trainer approach. We think that you can play a key role in mentoring your colleagues. You know, if you know how to manage obesity, you can have a seminar, you can have an in-service, you can use some of the aids, teaching aids, PowerPoints, and tools that we're going to provide for you to teach your colleagues how to better approach obesity in their patients. So we really endorse this train the trainer approach, and we hope you'll go through this session with Jamie and me with an eye to how you're going to make this material your own. So, Jamie, let's get started. And I'm going to turn it over to you with one of the most important topics, and that's how do we really talk to patients about their weight?
So yes, Donna, I think it's really important for us to think about all of the things that lead to inertia and really make it difficult for us to begin the conversation with our patients about obesity. Especially, we can all think about those times when someone comes into the office with a chief complaint that's not related to their body weight specifically, but in the back of our mind, we're thinking, well, if we were able to take care of the obesity, we might not have to deal with all of the complications that you talked about before that we often spend so much of our time focused on. And so one of those main things that, really drives the inertia is how do we start that conversation? How do we have a plan in order to be able to really sort of talk to our patients about something that can be really stigmatizing, right? Now, this would be easy if we were just talking about your blood pressure or your blood sugar, but because we're talking about body weight and all of the stigma and the bias that's wrapped up in that, a lot of our patients feel that stigma, and we felt that uncomfortable feeling And so it becomes hard to have that conversation. So let's talk about ways that we can do that. And I like the 5 A's approach that we have here, which starts off with ask permission. So we really want to start off with a compassionate and empathetic approach that says, I really want to get your permission to talk about this issue, because the patient may not be ready to talk about that, may not be interested in talking about that, or they may already have some ideas about what they want to do, and they're moving off in a different path in terms of their treatment strategies. Secondly, we want to assess their story. So this is basically just listening. We want to understand what their journey has been, the trajectory of their weight, where are they in terms of disease severity, and there are different ways that disease can be staged. The Edmonton obesity staging system is one example. And then we want to advise on management, and we want to talk about the different strategies, match that up to the goals. So agree on goals, and then think about how do we make an assist in terms of helping to drive change, get access to treatment, move that patient in the direction that helps get them closer to their goals. So that framework, I think, is a really great framework, but it starts with that first question of ask. In order to be able to do that conversation with some level of confidence, I think it's really important for providers to understand what are the etiologies of obesity. We've moved from the calories in, calories out, sort of very mathematical model, right? It's not a math problem. We're now at a point where we understand obesity is a complex chronic condition. It has lots of different factors that impact it. Some of these are fixed, like genetic factors. Some of these are physiologic, right? They are just built into how our bodies work and how our bodies are designed. And as a result of the environment and behavior, when you put all of those things together, you have what ends up being someone's body weight and how that body weight is distributed in terms of how much is in the fat stores, how much of it is in subcutaneous adipose tissue stores versus in other adipose tissue stores like visceral adipose tissue, and then how much goes into the organs, like you talked about the liver fat earlier. All of those things are determined by these factors that are largely out of our patient's control. And so I think it's understanding the complexity of this that helps give you some confidence in having that conversation with the patient, that it won't end up being something that becomes another stigmatizing or biased interaction with the patient. And the patient and you can walk away feeling good about that conversation. Here's an example of how social determinants of health, one of those components of the environment that really sort of has a direct impact on life course and obesity risk. Here's an example of how that compounds over time. And let's just take one generation into another generation. And you can see if someone starts out with pregnancy and they say live in a low resource neighborhood, they have a low income job, maybe they don't have full health care insurance. If they are pregnant, they're more likely to have poor nutritional status, they're less likely to breastfeed, the child may be more likely to be either low or high birth weight, and the mother may have difficulty having access to childcare or to maternity leave. That has implications for the child. And so that child may spend more time watching television, have more screen time. Low-income individuals tend to have a higher risk of food insecurity. And we know that paradoxically that leads to an increased risk of obesity. We also see, low resource neighborhoods having fewer outdoor spaces for activity or fewer places for healthier food options. And so as that child grows into adulthood, now they start to experience some of those social determinants and other programmed issues that lead to increased weight gain over their lifetime. And you see less social mobility as people tend to gain weight early in life. They have fewer opportunities when it comes to employment. And when you start to compound those things, you stay in the same neighborhood. And now that child grows into adult and becomes likely to be pregnant and have difficulty that reflects the same generational issues that her mother had. And when you see that start to compound over time, you start to realize, well, it's no wonder that we see a lot of the generational transmission of risk of obesity that happens across families because of a lot of these social determinants of health when we have poor mobility through our social economic status. Here's an example of how social determinants can actually really sort of change, even within a given class of obesity, the risk of early mortality. So this is age-adjusted mortality rates. And what you see for any given class of body weight, that in the darker maroon bar, you have the highest risk or the highest rate of age-adjusted mortality. So that gives you a sense of the direct burden that social determinants of health has on someone's risk of death. The other thing that really is, I think, important for us to understand in this context of trying to get away from the inertia of not doing anything when we talk about the treatment of obesity and getting this started is understanding what it is that makes obesity different and can make it difficult to really sort of move the needle, if you will, in terms of getting a treatment response. As I said before, it's not just about a energy in, energy out, and if you get the right number in or right number out, then you start to lose weight, and it's just as simple as that. There are a lot of metabolic processes that defend a body weight and make it difficult to move outside of a certain range. When you start to gain weight, you have factors that will help to normally move people back into that lower weight range. If you start to lose weight, we've all had opportunity or situations where we've been sick and inadvertently didn't eat for a little while. You lose a few pounds, but naturally you seem to gain that right back and get back into that previous body weight. Well, in obesity, that thermostat is off and it's protecting towards the higher side. And so people who have excess weight, it makes it even harder for them to move into a lower body weight, especially lose a substantial amount of weight and maintain that weight loss. They have an adaptive response that pushes them right back into that higher weight category. The thing that often challenges a lot of our patients is that they find that healthcare providers are negatively reacting to them as people. And you can imagine if you are a Black female, as Donna talked about earlier, where we see the highest prevalence of obesity by race, sex, ethnicity, what you end up seeing is a lot of the patients that I see with Black females say, look, I've had really negative encounters with a lot of healthcare providers, and I know that I can expect that in some instances because of who I am, right? Because of racism, because of different experiences I have as a person of color in the healthcare system. But there's some other things that are going on there, I think, Donna, when it comes to, the experience, especially of the heavier person, in addition to the racial issue.
Yeah. There's so many things that drive bias in this culture. There's such a cultural drive for slimness, Jamie. But there's, I think that I want to talk to us about implicit and explicit bias.
Yeah, so this is really an important part of, I think, that inertia conversation, because sometimes we may not be thinking that we are part of the issue, part of the problem, right? Because I'm open-minded, I treat all my patients the same, I believe in health equity. But there have been studies that show that just as you talked about in the culture, right, there's a cultural acceptance of it's okay to make fun of someone who's heavier, right? It's okay to think that someone who is heavier isn't maybe as, doesn't have as much willpower, right? They're not as disciplined. Because if they were, then they wouldn't be heavy. And so those types of stereotypes, those types of ideas and images, even though you may not really sort of understand, they hang out in the back of your head. That's implicit bias, right? So it's not the overt discrimination or shaming or disrespect, but it may be the, if you didn't have obesity, you wouldn't have all these problems, right? Or it may be even language, right? Using the word obese, right, to describe someone, to say you are obese, right, versus you have obesity. Those are two different ways of describing a person. And one says that you are the problem, right? You are the disease, you are obese, versus you have obesity, you have a disease. And, we will say, to people, you have cancer, but we don't say you're cancerous, right? And so those are examples of how bias may impact how we talk, how we act. And again, it may be implicit in that we don't really sort of fully have an awareness of it, but it comes out in the everyday behaviors and interactions, interpersonal interactions that we have with patients. And as a result, what we end up seeing in terms of patient care is that people with obesity are less likely to engage in a lot of preventive care. They avoid or delay going to a healthcare provider. They often switch providers because they're looking for someone who can be understanding and empathetic, or even just respectful. And those are really important concepts for us to understand when we think about trying to overcome that inertia. So the AAFP has, I think, some really nice guidance around how to think about managing obesity and evidence-based techniques for implementing that guidance. And it starts off with the very basics: see, acknowledge, and treat the whole person. Don't attribute every sign or symptom to obesity. I think it should be important for us to be a clinician, go through our differential, think about what are the other issues that may be leading to the complaint. And then if we've ruled those things out, then we take a look at, okay, what could treatment of obesity do to help this condition? Identify those biases and assumptions and really sort of do some introspection. I think it's important for you as a leader within your program or your clinic, your staff, to set an example, but also have a zero tolerance policy about stigmatizing language, right? So as you are teaching your staff to use people with obesity rather than obese patient or obese people, those are great ways to help, sort of start to change the culture. Using patient-centered practice, communication, those 5 A's that we talked about, using that as a way to help frame discussions. The environment and being welcoming is really important. We always say that our team at the front desk is an extension of us as providers. And if the patient has a good interaction there, they're going to be set to have a good interaction when they come back into the office. Even just the space in the office, right? The furnishings, the scale that you use, right? Having something that's accommodating in private. And talking to the patient, if you're going to weigh the patient, talk to them about why you're weighing them, right? So that they understand this is not just something that we, have to do. We do it with the intent and purpose of using that information. And then being a lifelong learner, and part of your participation in this program is really all about making sure that you continue to learn and then you teach those who work with you.
But let's move on now. And I just want to talk about the different options that we have available to help our patients lose weight to achieve health benefits. Look, what we're in this for is not cosmetic weight loss. This is all about medical weight loss. It's about helping patients achieve health benefits mediated through the physiology of weight loss. So if we look at our treatment options, we've got a toolbox, right? We have nutritional intervention, diet, physical activity, behavior. It's usually around diet and physical activity, but also around sleep, stress management, and then pharmacotherapy and bariatric surgery. And just like the rest of medicine, we pull tools from the toolbox to help our patients based upon the severity of their illness. So we use bariatric surgery for patients who have more severe disease. We use our medications for individuals who have a BMI of 27 with a comorbidity or a BMI of 30 and up. But look, many patients can benefit from lifestyle recommendation. And it's so important to recognize what's going on in our medications for obesity. This is the golden age of obesity medications. We finally have some tools that are safe and effective, and we have great data about how these medications can help more people achieve more weight loss, get more health benefits. So here what I'm showing you are the currently available medications sort of stacked up against our bariatric surgery procedures. So over on the right, we have the weight loss we typically expect with sleeve gastrectomy, the most common surgical procedure in the United States. It's on average about 25% weight loss at 2 years from the procedure, and a little bit more with Roux-en-Y gastric bypass, about 28 or 30% weight loss on average. Our older medications, well, if we gave those medications with a good lifestyle intervention, we could get 8 or 10% weight loss, maybe. So here I'm showing you phentermine topiramate, average weight loss in the study that's being cited there, 8.6% weight loss. Naltrexone bupropion, 6.1%. The very first GLP-1 that was approved for obesity management, we got 8% weight loss. It was about 5% weight loss greater than placebo. But look, the big change is with these second generation GLP-1 based medications. So semaglutide, almost 15% weight loss on average. Tirzepatide, a little more than 20% weight loss on average. This is rivaling bariatric surgery. So what's going on here with these medications is based on our understanding of the regulation of food intake. We have targeted the gut-brain axis. So the GLP-1 is a hormone produced by the L cells in the small intestine that's stimulated by a meal, by nutrients entering the small intestine. It's a signal. It's a signal to the brain that food is on the way, and it reduces appetite and it promotes satiety. It's also a signal to the pancreas and to the liver, and it reduces blood glucose if blood glucose is high. It promotes insulin secretion if blood glucose is high and helps control glycemia. So these GLP-1 medications have come from approval for diabetes into the weight management era. Our older medications were medications that worked in the brain. We had phentermine. This is a dopamine norepinephrine stimulating agent. And then we combine that with topiramate, a GABA receptor targeted agent. We have a combination weight loss medication, phentermine topiramate. We also have naltrexone bupropion available for our use, these older medications. So I think we need to recognize the standard of care. The standard of care for obesity is that our providers should not sit back and wait for patients to ask for medications. We need to identify patients who would benefit from weight loss, aided by these biologic aids, that these medications work through biology, through appetite, to help patients eat less, lose more weight, and achieve health benefits. You know, we're frequently asked, how long do these medications work? And here's some evidence for you. So this is from the SELECT study, and it's 4-year data on semaglutide compared to placebo, and it's in 17,000 patients, over 17,000 patients. And as you can see, we can see long-term weight reduction with semaglutide. It's really more than 4 years of observation, so that's very good. We know that if we can continue these medications, we will sustain weight loss. And then I'm showing you on the right some data about changes in BMI category. And I think the important thing here is to recognize that some patients with these newer, robust medications are going to achieve so-called normalization of BMI. In this study, 12% of the patients on on semaglutide achieved a BMI of less than 25. That's the so-called healthy range. And an additional 45% moved from an obesity category down to an overweight category. And that's also another important milestone. But let me tell you, these medications also have effects not just in producing enough weight loss to produce health benefits, but they also have pleiotropic effects throughout the body. So we know that they have effects on glycemia, they have effects on appetite, they also have effects on inflammation. These are powerful anti-inflammatory drugs. They also improve coagulation, they promote natriuresis, diuresis, they lower blood pressure. And what we're seeing emerge from the studies in these medications and ongoing studies is that we're seeing that these that the GLP-1s and the GLP-1 backbone medications like GLP-1 GIP combination is that they are going to have disease modifying properties across a spectrum of chronic diseases. It is such an exciting time. So this part of the program is going to be on breaking through biases, uncovering practical strategies to engage and motivate persons with obesity. And we're going to do 2 case presentations. So this is Mike Simons. He's a white man. He's 52 years old. He owns a car dealership, and he requires frequent socializing and business entertainment over drinks where he has a lot of rich, high-fat foods. He's been depressed for 6 months and is in relationship to his divorce. He's been working out at the gym 2 days a week for about 8 months. He appears frustrated that he's never initiated a conversation with you about his weight in the 15 years he's been your patient. And today he's coming in, his chief complaint is about his twisted ankle at the gym. So he has a medical history of obesity, hyperlipidemia, hypertension, and sleep apnea. He also has the recent diagnosis of depression. In his family history, his brother had diabetes and hypertension. His father had prostate cancer. His mother an MI and dyslipidemia. His BMI is 36. His weight is 298 pounds. His A1C is 6.2. That's pre-diabetes. He's got a blood pressure could be lower, 138/87. His total cholesterol is 180. LDL 90. Okay. HDL, I don't like it this low, 40. Triglycerides, 250. That's borderline. This man has metabolic syndrome. His current medications are statin, a good one, rosuvastatin, and then he's on benazepril, hydrochlorothiazide, and paroxetine. Jamie, what do you think?
Yeah, so this is an interesting case. And, you know, in this situation, we have to deal with the chief complaint first, right? Which is he came in with an ankle injury, twisted ankle. And I think there's an opening here to be able to, you know, we can start to talk about that relationship between your risk of injury and a higher body weight. There's evidence here that shows, you know, you're going to have a higher risk of lower ankle, lower leg injuries when you have a higher BMI. And I mean, I think we classically think about osteoarthritis and other sort of big joints, but those ankle injuries and foot injuries are certainly an issue as well. So I think as we address that, then if we think about what we want to do in terms of going to, you know, think about these other risk factors, is this an opportunity to have that conversation? So if we think about the constellation of issues that he has, as you said, he correctly, he has metabolic syndrome, right? And we now have this new model of cardio kidney metabolic syndrome, which really starts to recognize the real sort of relationship between excess adiposity, especially in the visceral adipose space. So once we feel that subcutaneous space, we're spilling over into the visceral adipose space. And that, through a cascade of insulin resistance, inflammation, and other factors, then leads to all of these downstream risks that we see, ultimately ending in that stage 4 end organ damage, where we've got cardiovascular events and stroke, and we've got AFib and heart failure and peripheral vascular disease, all of those things. So this is where he is heading if we, don't help him really sort of head that off. He's been really active, right? So you pointed out that he's going to the gym, I think, a couple of days a week, and he's been doing that for 8 months. So he's clearly very active and seems to be motivated to stay physically active. And that's a good thing for him, because there are data that show that if you're inactive, even within a given category of body weight, you will tend to see a higher risk of disease. And so that's a good thing that we can build on. But there are lots of little things that I think that we can identify that begin to help move things in the right direction. So what do we need to do? I mean, I think in my mind, Donna, the first thing I would do is say, would it be okay to talk about your weight and your health today? Let's talk about the relationship between your weight and your ankle sprain. That may be something that he may not be fully aware of. And it could be an opportunity to have that conversation. I also like to use the question of, is there anything about your weight that's been bothering you? Right? Because now I'm not saying that I have a problem with your weight. I'm asking, do you have any concerns about it? And if you do, if you say, look, it's going to be harder for me to walk around on this ankle with my weight where it is, and I've been frustrated. I've been trying to go to the gym and I can't get any weight off. Donna, I mean, that data just as well as anybody, right? Can you exercise it off? No. Yeah. So it's clear to me that there might be an opening here. And so if he says yes, then we're going to move through that 5A's assessment, right? And assess his story and then think about what are the benefits. And so we can use a tool like this to really guide our discussion and talk about what are the reasons you might have for losing weight. Maybe it's getting his blood pressure under better control. Maybe he wants to get off some of his medication. Maybe he's afraid of type 2 diabetes. His brother has type 2 diabetes. He doesn't want to have it. And we've got targets, like you talked about before, that we can get to with certain therapies. And that can be the beginning of the conversation in terms of treatment. The other thing that we can do that is in that low-hanging fruit basket is really, sort of talk about, is he on medications that might increase his weight? Because that's a simple one in a lot of instances. A lot of times we might have an alternative to something that might be promoting weight gain. And for him, the paroxetine could be, a culprit, right? I mean, that's been associated with about 5 to 10 kilos of weight gain on average. And so if you go back and look at his history, he's got a history of depression. You can go back and look in the chart. The nice thing about the electronic medical record, right, is you can actually graph the weight and you can see, when did I start the paroxetine? Oh, and what happened to his weight after that? So you've got at least a temporal association that can be really useful. And that then gives you a chance to talk about alternative medications that may be less likely to support weight gain, or there could even be an option that helps with weight loss, like bupropion. The other thing that you can do in terms of starting to help move him towards treatment is think about the dietary approach in dietary counseling. And in this case, you don't have to be an expert, but you can point out some basic things like reducing his alcohol intake. That's going to have a lot of health benefits, right? It's going to help lower his blood pressure, probably improve his insulin sensitivity. He's probably going to have some better sleepful nights, maybe even help his mood, eliminating sugar sweetened beverages. So when he's going out, opt for the 0-calorie options. But ultimately, if he wants to get a structured plan, if you don't have a resource in your office, having him referred out to a dietitian, to a nutritionist, someone who can give him some time and expert advice on how to really sort of use a tool that may help him make better choices more consistently, help him with some portion planning, meal planning, how to choose the right types of proteins, all of those types of things. A dietitian can be a real asset for you to lean on in terms of helping your patients. And then ultimately, when we get into thinking about prescribing a medication, right? So you mentioned we shouldn't be waiting for the patient to ask should a medication be prescribed, or if he's been working on a lifestyle treatment strategy and not having any results, now is the time to escalate therapy. And pharmacotherapy, in addition to that lifestyle treatment, can now be successful, help him be successful. And so we're targeting a 10% weight reduction. If we look at this particular tool that we have, it gives us a really nice layout of what's the probability of hitting a particular target on average with a given medication, and then what are the potential side effects that we need to look out for and help the patient manage or anticipate as we start to escalate the treatment and move them from a lower dose to the higher target dose. And so you can see there are a number of different options here, from GLP-1 based treatments to ephedrine, topiramate, even a naltrexone or liraglutide, naltrexone bupropion or liraglutide has some chance of getting him to a target. And it's important for you to understand these treatments and not just rely on, oh, I'm going to go to the GLP-1 based treatment once weekly, semaglutide or tirzepatide, because access to these treatments is still limited in a lot of people's, a lot of cases, right? It's expensive out of pocket, and insurance coverage is inconsistent at best. So you want to be familiar with all of these options so that you can help your patient who's ready to move on to treatment. And then this is a nice tool that just helps remind you about how to titrate and what your dosing schedule is. No need to go into all of the details here, but I think keeping something in mind about how to start your patients appropriately will save them a lot of side effects, right? That's the whole purpose of making sure that you start low and go slow. Let's wrap up, Donna. I mean, what do you think here? If we really sort of work on the low-hanging fruit, we get him started on some type of pharmacotherapy that is accessible and appropriate, and then we talk about the medication that he's taking that we could potentially switch to, help promote weight loss and maybe prevent weight gain that's occurring because of the medication. I think those could be, 3 actionable items, and then referring to a dietitian. That could be a really sort of robust treatment plan to get started with.
Yeah, I feel really optimistic about this patient. He's got a lot going for him. So, but to me, the most important thing about this patient is to keep him coming back. Obesity is a chronic disease, and we're not going to cure him in one visit. It's this patient has been coming to you for 15 years, and hopefully he'll be coming to you for 15 years more. And so I think over time, you can make a lot of incremental improvement. I know you've seen that in your practice, Jamie.
Yeah, absolutely. I always tell the patients, look, our first treatment strategy is our best guess based on what we know now. And we're going to learn a lot based on how you respond to this treatment strategy. And then we're going to make some changes as we go along. And so your job as the patient is to give us feedback and let us know what's working and what's not. Our job is to figure it out as the clinician team in order to give you the best chance to be successful. And so that's a great partnership when we set it up that way. Let's get to our second case. I'm really interested to pick your brain about this one. So this is Janice. She's a Black woman who's 59 years and comes into the office today. She's a school secretary who's been referred by a colleague. She's coming to the specialist, Dr. Ryan, for weight management. She wants the best. So she doesn't want to end up like her parents. And her parents both had type 2 diabetes, pretty bad. Father had some amputations, mother's on dialysis. And she was diagnosed with type 2 diabetes recently. So now she's really motivated. She's had hypertension for about 8 years. Her BMI is 34, and weight currently is 212 pounds. She's got an A1C of 9%, which goes along with kind of a new diagnosis of type 2. Blood pressure is 126/86. Renal function's not so hot, really, and there's some room for improvement there, certainly in her lipids. Triglycerides, I would like them to be less than 150, and her HDL certainly is low. Tend to see that, kind of combination often. And so medications currently, she's on lisinopril. She's on some supplements with, omega-3 fatty acids, and she's taking metformin. for her type 2 diabetes. So what would you do with this patient, Donna?
I love this patient, Jamie. This patient is the window of opportunity. She's already said, I'm not going to be like my parents. I'm not going to be the patient with a chronic disease that we treat, we follow to failure. Then we try something else. And when that fails, we try something else. No, I love this patient. I'm going to talk to this patient about moving her upstream in the diabetes course. And so, I think it's so important to use weight and weight management as the real underlying driver of diabetes, and weight loss as a way to move patients upstream, to move them from dysglycemia to prediabetes, and maybe even to normal glycemia. So I think for the newly diagnosed patient with diabetes, it's a window of opportunity. But even though I am really interested in staking out a weight loss goal of 15% or more, I'm not going to neglect the other risk factor management in this patient. And, in the patient with diabetes, we want to manage LDL. Her LDL is too high. We got to get her on a high intensity statin. We need to get her on a platelet inhibitor. Her blood pressure is okay, thank goodness. She's on the lisinopril, and that's probably good. So we want to cover all of those bases at the same time. But I still am going to try to talk her into an aggressive weight management approach. So I think there is some evidence. We have evidence from bariatric surgery that with the amount of weight loss with bariatric surgery, we can move patients upstream. They don't always stay there. Depending on how long their diabetes has been present, the diabetes may still progress. But the same thing is true from studies from the UK, the DIRECT study, that if patients can achieve 15 kilograms or more weight loss, they have a pretty good chance of becoming euglycemic, normal glycemic. Again, if they regain the weight, they're likely to regress into the diabetes coming back. So my goal in this patient is to achieve and sustain at least 50% weight loss with her. I think if you look at the ADA guidelines for this, their recommendation for patients like this who need good weight management, central weight management, is the GLP-1 and the newer GLP-1 medications that produce robust weight loss. But I'm concerned about that kidney dysfunction. And I'm also concerned about this patient's risk for cardiovascular disease. And, the GLP-1s and the SGLT2 inhibitors in the ADA guidelines, they're both recommended for, to reduce progression of renal disease and to prevent cardiovascular disease. So I will be thinking about those two medications in this patient. So I'll be thinking about either canagliflozin, dapagliflozin, empagliflozin, and I want this patient on a second generation GLP-1 receptor agonist, either semaglutide or tirzepatide. I think, our approach to type 2 diabetes has really changed. Instead of the intense focus on glycemia and glycemic control, I think at all cost, I think that we really need that the emphasis has been on this weight-centric management, because weight plays such a key role in the progression of diabetes. So I'm showing you here the weight loss efficacy of the medications that are approved for use in people with type 2 diabetes. And as you can see, these newer ones, tirzepatide and semaglutide, they have pretty robust weight loss. Not as much as we see in our patients with obesity, because patients with diabetes don't lose as much weight. But if we give these medications with a powerful lifestyle intervention, I believe I can get 15% weight loss in this patient with either semaglutide or tirzepatide. I'm going to try to do it. But I want you to notice that if you take an approach of, say, starting insulin in this patient who has an A1C of 9, you're likely to promote weight gain. Same thing with the TZDs. The sulfonylureas also. No, not for me. I want the medications that are associated with weight loss. Jamie?
Yeah, I totally agree. I think you're right on in terms of the difference between a glucose-centric, sort of view versus a weight-centric approach. And, the world has turned to say a weight-centric approach in terms of management of type 2 diabetes, when obesity is present, is really important.
So these are the weight loss studies in people with diabetes on either semaglutide or tirzepatide. And as you can see, on average, the weight loss with semaglutide at the top dose was about 10%. With tirzepatide, it was a little over 15% on average. There's variation around this. Some people are going to lose more, some people will lose less. But I think either of these medications gives our patient a good chance of achieving my goal of 15% weight loss. Okay, let's sum it up. What do you think? How did I do?
A plus, if I had to give a grade. There you go. So you highlighted a few different things. One is, as we are working on the weight and getting those risk factors improved through weight reduction, we're still going to aggressively treat those risk factors. That comes from very early guidelines. I think that you helped to write from 2013, where you said you want to get those risk factors under control. There's a window of opportunity, and so we want to go for it, right? She's motivated. You're telling her now that she doesn't have to have type 2 diabetes. Through weight reduction, she can actually put it into remission. And that's a great way to, sort of help coach her to understand the importance of the weight management. And, I think someone like this is going to be motivated. So you're probably going to want to see them back early on to make sure that their initiation into treatment is fairly smooth. What's your advice about, if you're going to start her on a GLP-1 based treatment, how soon are you going to have her come back into the office to check in on things?
Oh, yeah, at least at the first month. But I really want her to have the phone number and to call in. I need to make sure that she's well briefed and can avoid some of the side effects with the dose escalation. So I really want to keep close tabs on her the first 3 months, see her at 1 month intervals, and then really have phone conversations or maybe a Zoom visit if there's a problem.
Excellent.
Okay, Jamie, we've got to train the trainer now. So, this is all based on the CDC training of trainers model. And I think the idea here is that, look, we learn from our peers. I've learned so much in medicine from you, Jamie, Ard, and from my other colleagues. And so I think what we're hoping from this is that people will take this away. So would you give us a little tutorial on how to be a good trainer?
Yeah, so you're right, Donna. I think we've all learned in medicine through a mentorship kind of model, right? I mean, it's largely about apprenticeship, about learning from our peers or from key opinion leaders, people who have the knowledge and then can depart that knowledge. They say, see one, do one, teach one, right? And so this is no different in terms of being able to spread the word that, hey, we can actually do something about obesity, and there's a strategy that allows you to be successful with that, with your patients. And, there's not enough of us out there in terms of those of us who spend our days and nights dealing with obesity and are, sort of steeped in this on a regular basis. So we need as many people as possible to help be, a part of that education train that allows us to spread the word about how we can do better for our patients with obesity. So we're going to go through very quickly some resources that are available through this activity that give you the tools that you need in order to really kind of help have a structured way of approaching this content and sharing that with your colleagues. So we encourage you to download all of these wonderful resources. They've been vetted. They are, excellent tools, and you can then begin to take your own, sort of resources, put your own spin on things, right? Your region, right? What Donna may need in her toolkit may need to refer to some red beans and rice and etouffee. And, here in the Carolinas, I might need to talk about some barbecue or something like that. That's going to be a little different based on the region. In the model of training of trainers, there's some basic things that you want to manage and make sure you're proficient on. You want to help your participants understand what the resources are. You want to be interactive in leading discussions and listen, being able to engage with your participants in terms of making observations about the insights that they're having. Or maybe there's something that they're not quite getting and you need to slow it down and review that concept a little bit more. But ultimately, your job as a trainer is to really support those who are coming to learn from you and make them comfortable with the content. So here are a few steps that you can follow that help you sort of get prepared for what you need to do when you're setting up your own training. Collecting your resources, getting your colleagues aware of what it is that you're doing, putting together all of your surveys and worksheets and making sure that you have those ready to go. And then at the time that you're ready to provide your workshop, having a really sort of well-defined plan for how you use that time. None of us like to be in a situation where we feel like it's disorganized and you're not making good use of time. So you want to be really respectful of that. And then follow up. Make sure that everybody got what they needed out of the activity. And then make sure that you've answered any questions that come up as people continue to review the material. So when you are thinking about the workshop that you want to put together, certainly the crowd that you have, the people that you have in that interaction will make a difference in terms of how that session goes. So having people who are open and ready to engage, and then also having people who understand that they're there to train and then go out and do the same thing and share information. So they need to be confident and have that skill of listening as well as public speaking. And then you want people who have a positive attitude and a can-do attitude, because this, we all admit, right, working in this space can be challenging, can be difficult, dealing with the hassles of getting access to medications and having the challenges that a lot of our patients will have. It's sometimes feels really hard, but you got to have that positive attitude, bring that to the team. And I think that it makes a big difference in terms of, getting people to engage in a training. So in terms of preparing, you want to do a few things that I think are really important to help set you up for success. There's a baseline survey that we would recommend that you use to really kind of understand where is your audience in terms of their current skill set and knowledge base. You got a slide library that you can pull from to build your slide deck. Lots of really great content, things like what we've used today. And try to stay interactive. No one wants you to just read off of a slide. We want you to, give your opinion, give your thoughts. If you have, differing sort of a range of ideas, or if there are questions that you can ask that are provocative, role playing is a great way to get people engaged. And then invite a patient to speak. We've done that a lot more these days, Donna, in terms of engaging the patient voice, because that's why we're here, right, is to really work with our patients. And what better way to get that experience, that firsthand knowledge of that, than to have a patient come in and talk about their experience. Have you seen that happen in things that you've done, in trainings that you've done?
Oh, I learned so much from patients. The patients are the key. Yeah, they make it so real, Jamie.
Absolutely. So when you get the baseline survey back, you really want to look at, okay, what are your gaps? What are the areas that you need to target your content to? The attitudes that people might have towards patients with obesity? What are the challenges that they're facing? Those are some of the things that you can highlight. And then when you think through your presentation, I think it's really important to level set on those issues of stigma and bias, like Donna and I talked about early on, and just acknowledging that and giving people a chance to reflect on that. Showing them the evidence in terms of how obesity science has evolved over time, and giving people a chance to really sort of come on board with those ideas, because those are central to really sort of building the rest of the content and the arguments. And then thinking about the complexity of obesity, how do we weave that into the materials and help people understand this concept of shared decision making, because I think more than any other space of medicine, patients really have agency in terms of thinking about what treatments they're interested in, what they've seen, what they've heard, especially nowadays, right? You can't open up your phone or a web page without seeing some headline about new weight loss medications, treatments, options, and so forth. So people are more informed, and that means we have to be more informed in order to help them make good decisions. I think these are some basic tips about, just how to engage your trainers, things that I'm sure all of you will do very well, maintaining that eye contact, being positive, being good in terms of your public speaking skills, about clear voice and using your hands and gestures appropriately. Keeping the crowd engaged is just a really important part of making sure that you're setting your trainers up to be successful. And then there's a nice worksheet around self-reflection that can be used to help set up a good group discussion. Things like, what are your biggest challenges in trying to offer treatment to your patients? What ideas does a group have about being respectful and evidence-based in terms of obesity management in that area? And what are kind of, support options that they might have for their patients that wish to begin obesity treatment? After the workshop, there's still a little bit of work to be done. So you want to follow up with your participants, make sure that they got the key learning points, the key objectives. I think a good post-test check is helpful, but then doing something even beyond that to really sort of help make sure that people were clear on those key points around bias and stigma, around the complexity of obesity. Maybe there's some nuanced things that you might need to send out a follow-up about. Where there are, opportunities for people to practice their new skills. So offer maybe some shadowing opportunities. If there's something that you are doing in your program that maybe other people are interested in seeing, see if you can open up an opportunity for someone to come in and shadow. And then think about the public health angle here. How do we engage the community? Are there resources in the community that you can bring into that workshop, into that training, or connect people to later on that can be useful? So for example, I think a good idea would be thinking about, are there food bank options in your community where you've identified food insecurity, and you can connect patients who might be struggling with food insecurity and obesity into those food pantry options that might be a useful tool and resource that someone didn't have, or having a good dietitian, right, that you can refer to. So being able to share that resource with the trainers could be a really useful follow-up activity. So, Donna?
Yeah, I'll try to bring this home, Jamie. Listen, what have we tried to teach today? Okay, ask permission. So it's a sensitive topic. So it's easy. We're going to say, is today a good time to talk about your weight? What if they say no? Well, you say, well, we'll bring this up at the next visit. Is that okay? But most of the time, your patient is going to say yes. Okay. Examine your own self for intrinsic bias, because stigma is absolutely an important factor in your patient's health. Patients with obesity feel judged, and they don't get the medical care that they deserve. We need to be aware of stigma and to fight it wherever we can. Look, foundational to any weight loss effort is diet and physical activity, as well as good sleep and good stress management. Yes, these GLP-1 receptor agonists and the GLP-1 backbone medications, they are unbelievable. They are fantastic. They really are wonderful for reducing weight loss, and they appear to have many, many positive disease-modifying attributes. But they're not the only medications. We need to be knowledgeable about all of the approaches to weight management, because weight management is the key to good health for our patients. Our appointment books are filled with patients with all the chronic disease, and obesity is a driver of all those chronic diseases. So we need to develop our skills in good weight management. Janie and I are both obesity medicine specialists, but we believe you can become obesity medicine specialists too, and you can become good primary care providers who have good weight management skills. So thank you so much for your interest in this. I hope you will take up our challenge and do some in-services, some symposia, and some meetings with your peers. So that's the end, Jamie. That's the end of our presentation. I want to thank my co-chair, Dr. Jamie Art, for his excellent leadership and discussion. Jamie, thank you.
Well, thank you, Donna. It has been my pleasure, as always, to spend time with you and to learn from you, and to be doing such, important work here in terms of helping to build a group of people who can go out and spread the gospel of obesity treatment, right?
Absolutely. Absolutely. And to all of the attendees, I hope you found this information informative and helpful as you strive to develop a relationship with your local primary care professionals who can help manage people with obesity. I encourage you to download the resources, the PowerPoint slides, and the practice aids, and from the menu that you see on the left side of the screen. So thank you. Thank you again for your participation.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/TBR860.